Okay, so this is just going to be a brief overview of renal failure, and it's just designed to give a general idea of what we look for when determining the different types of renal failure, and it's just going to be really broad. So we're not going to talk about the various causes of renal failure. We'll go over those more in detail in a different section. So, what is acute renal failure? So, when we talk about acute renal failure, what we're really talking about is renal insufficiency. So, it's when the kidneys aren't doing their job. And there's numerous causes, and primarily we divide these up into pre-renal, which is before the kidneys. So, the cause is somewhere before you get to the actual kidney. Intrarenal, so the problem is within the kidneys, and that can be tubular or it can be glomerular. And then post-renal, which means that the cause is after the kidneys. So renal insufficiency can be synonymous with azotemia. And that's just simply an elevation of the BUN and creatinine levels. So you don't necessarily have symptoms, you just run labs on a patient and they have elevated BUN and creatinine. That's azotemia. Now, if the patient starts to have symptoms of renal failure, and it's not just the lab numbers, but it's lab numbers and symptoms, then the diagnosis shifts from azotemia to uremia, and the patient will probably need hemodialysis. So, what does uremia cause directly? So, when you have high BUN and creatinine, what can that directly cause on your body? Well, it can cause pericarditis. Why? Because the urea inflames the tissue of the heart. The pericardium is just really sensitive to those kinds of toxins in the blood. It can cause bleeding, and that's because the platelets don't function, and we can get around this by prescribing DDAVP. But if the patient does have bleeding diathesis and they have azotemia, it's probably an indication for hemodialysis. It also causes a susceptibility to infection, and that's kind of the same reason why it causes bleeding. You may have platelets, you may have white blood cells, but your cells can't function if they're being bathed in urea. So the white blood cells can't degranulate, and so even though you have healthy white blood cells, if they can't degranulate and do their job, then you're going to be susceptible to infection. So that's what uremia causes directly. So when do we dialyze the patient? The good way to remember this is A-E-I-O-U, so our vowels. So if the patient is acidotic, and it would be metabolic acidosis, we're going to want to dialyze the patient. Why does the patient become acidotic in renal failure? Because the patient can't get rid of hydrogen ions. They can't get rid of protons in the distal tubule. So because of that, and in the collecting duct, because of that, they're not getting rid of protons, they're maintaining hydrogen ions, and they're going to, their pH is going to drop in their blood. So metabolic acidosis, acidemia is an indication for dialysis if it's a renal cause. Electrolyte abnormalities, so E. Electrolyte abnormalities with EKG changes. What is going to be the electrolyte abnormalities that's going to cause the EKG changes? It's going to be hyperkalemia. Remember that the kidney is responsible for getting rid of potassium. And so if we can't get rid of potassium, then it's going to build up in our blood and it's going to affect the heart conduction system. And remember on EKG, if you have hyperkalemia, you're going to see peaked T waves. Intoxication, so these are acute causes of renal insufficiency. And the way to remember the causes of intoxication is slime, S-L-I-M-E, and that's salicylic acid, lithium, isopropanol, magnesium-containing laxatives, and ethylene glycol. And then another I that can cause renal insufficiency is infection, and remember we just talked about that. So infection related to uremia. If the patient has elevated BUN creatinine levels and they have an infection, then it's safe to say that there may be an infection related to uremia. And so that can be an indication to dialyze them, because if we lower the BUN creatinine levels, it will enhance the white blood cells' ability to function, and thus help the patient fight the infection. The O is overload of fluid, not responsive to diuretics. And the U is uremia complications like pericarditis, encephalitis, and GI bleed. So the treatment for renal insufficiency, be it pre, post, or intrarenal, is going to depend on the cause. But first we have to be able to discern whether the renal insufficiency is pre, post, or intra. And we do this on labs. So our CMP and urine tests are going to be most useful. So here are some of the labs that we're going to look for when we want to discern the type of renal failure. So first we're going to want to look at urine sodium. And what urine sodium is it's simply the concentration of sodium in the urine. Fractional excretion of sodium is your percentage of sodium excreted in the kidney that is filtered in the urine. So normally 1% of the sodium that's excreted in the kidney is filtered into the urine. And so fractional excretion sodium is not going to be as important as you might think, and I'll show you why in a little bit. Urine osmolality is simply the concentration of solutes in the urine, and this is going to correspond to how much water is in the urine. It's not going to correspond to how much sodium is in the urine. Urine osmolality is responsive to how much water is in the urine. So if you have more water in the urine, then you're going to have a low urine osmolality. So when the urine is concentrated, if you have low water in the urine, then you're going to have a high urine osmolality. Urine being concentrated just means we're pulling water out and reabsorbing it into the bloodstream. If you have a low urine osmolality, it means the urine is dilute. It means we're allowing more water to be filtered out into the urine. And so you'll have a low urine osmolality when the urine is dilute. So you can think of this as just on the spectrum of the reabsorption of water. If you have more reabsorption of water back into your bloodstream, the urine's going to be concentrated and you're going to have a high urine osmolality. If you're excreting more urine and not reabsorbing the urine, you're going to have a low urine osmolality because there's more water in the urine. The BUN creatinine ratio is simply the ratio of BUN in the serum to creatinine in the serum. And the normal range is between 10 to 1 and 20 to 1. So when there's more reabsorption, our BUN creatinine ratio is going to be higher. Why? Because BUN is absorbed in the kidney, in the nephron. So if there's more reabsorption going on for whatever reason, there's going to be more BUN reabsorbed back into the bloodstream. So our BUN creatinine ratio will go up. If there's less reabsorption for whatever reason, our BUN creatinine ratio is going to go down. Why? Because there's less reabsorption, and so there's less reabsorption of BUN. So our BUN creatinine ratio will go down. And then, of course, the presence of blood cells, casts, and sediment, that's all going to point towards intrarenal failure. So here's our fractional excretion of sodium, and this is why it's not important. Remember we talked about the urine sodium? Urine sodium is very easy to remember. If there's low urine sodium, it means that we are not reabsorbing sodium. So you can think of as urine sodium is lower, this number is lower, what's it going to do to this fraction? It's going to be lower. If urine sodium is higher, this number is going to be higher, and so this whole fraction will be higher. So as long as urine sodium is low, fractional excretion of sodium is going to be low. It'll be less than 1%. If urine sodium is high, then the fractional excretion of sodium is going to be high. So you don't really need to know both of these. Okay, it's good to know that if fractional excretion of sodium is greater than 1%, it's high, and if it's less than 1%, it's low. But these are always going to correspond. Urine sodium and fractional excretion of sodium are always going to correspond. Okay? So let's kind of look at our labs here in comparison. So one thing that's really important to get into your mind is that even though pre-renal and post-renal sound like they should be the opposite, the labs are really similar. So pre-renal and post-renal, you're going to have a low urine sodium. You're going to have, therefore, a low fractional excretion of sodium, less than 1%. Because you're in pre-renal and in post-renal, you're reabsorbing water, your urine osmolality is going to be high because we're pulling water out of the urine and back in to the bloodstream. We're doing it for different reasons in pre and in post, but we're reabsorbing water nonetheless. So the urine osmolality is going to be high. Because there's more reabsorption happening, both of sodium and of water, we're going to reabsorb more BUN. And so both in pre-renal and in post-renal, we're going to have a high BUN creatinine ratio. It's more pronounced in pre-renal than in post-renal, but in both cases, they're going to be roughly around 20 to 1 or higher. In the intrarenal causes, what we'll see here is it's going to be the labs are going to be more glaringly obvious in the acute tubular necrosis and the acute interstitial necrosis. So we break up intrarenal into acute tubular necrosis and acute interstitial necrosis, and then glomerulonephritis. And the reason they're different is because glomerulonephritis happens at the glomerulus, and ATN and AIN happen in the more distal part of the nephron. And so remember what the glomerulus does is the glomerulus is responsible for filtering from the afferent arteriole. So you can imagine that if you're filtering from the afferent arteriole and that part is disordered, you're going to have red blood cells going into the filtrate, you're going to have protein going into the filtrate. So what we really look for in the urine, if we want to diagnose glomerulonephritis, is we look for red cell casts, hematuria, and proteinuria. If it's acute tubular necrosis or acute interstitial necrosis, what's the part of the nephron that's going to be disordered? It's going to be the tubules. And what are the tubules responsible for? They're responsible for reabsorption. So the part that's going to be disordered is going to be where we reabsorb sodium and where we reabsorb water. So because we can't reabsorb sodium, the urine sodium is going to be high. We can't pull sodium back from the tubule into the bloodstream. So more sodium goes into the urine. And so since the urine sodium is high, the fractional excretion of sodium is going to be high. And because we can't pull water out, we can't reabsorb water because the tubules are damaged, we're going to have a low urine osmolality. And so there's going to be a lower concentration because we're going to have more water in the urine. We can't pull that water out of the tubule and back into the bloodstream, so we have more water in the urine, and therefore we have a lower urine osmolality. So what's basically happening here is the kidney, the nephron is not functioning at all. You have no sodium reabsorption and very low water reabsorption, and therefore we have a high urine sodium and a high fractional excretion of sodium and a low urine osmolality, which simply means lots of water in the urine, low reabsorption of water. Our BUN creatinine is going to be low. Why is it going to be low? Because we can't reabsorb BUN. Reabsorption is really the big problem with acute tubular necrosis and acute interstitial necrosis. So because we can't reabsorb BUN, we're going to have a low BUN creatinine ratio. So in acute tubular necrosis and acute interstitial necrosis, these labs are going to be just completely the opposite of what we would see in pre-renal, glomerulo, and post-renal. What you're going to see coming out of the urine, if you look under microscopy, is you're going to see brown casts and epithelial casts. What are those? Those are the cells that make up the tubules. That's acute tubular necrosis. You have necrosis of the tubules. In acute interstitial necrosis, which is generally going to be an inflammatory cause, you're going to see eosinophils. Okay, so what I want you to look at here is, this is sort of a review of our physiology. So this is the afferent arteriole here. This is where we go through the nephron. This is really just a schematic. And this is the efferent arteriole. So what allows us to filtrate from the afferent arteriole into Bowman's space in the glomerulus? What it is that we have a high pressure in the afferent arteriole, and we have a relative vacuum, a low pressure, in Bowman's space. And so because there's a high pressure to a low pressure, there's a gradient that's going to push solutes from the afferent arteriole into Bowman's space. When you have pre-renal failure, what happens is that you're having a decreased blood flow through the afferent arteriole. So this pressure in the afferent arteriole gets lowered. Because you have a lower pressure in the afferent arteriole, this gradient between the afferent arteriole and the Bowman space is going to be reduced. The high pressure is lowered, and so you have less of a gradient, so you can't push solutes that you need to push through. You can't push them through as easy because you have a lower gradient. And so that's going to reduce your glomerular filtration rate, and thus we're going to have less filtration. Now, on the other hand, when you have post-renal failure, what's happening is that you have an obstruction. You have an obstruction downstream of the kidneys, and the pressure is going to build up in all your nephrons, and that pressure is going to transmit back to Bowman's space, and this low pressure that you're supposed to have in Bowman's space is going to go up because we have an obstruction distal. And so because this obstruction goes up, because this low pressure goes up, you have, again, less of a gradient, and so your glomerular filtration will go down. And so you can see that in both pre-renal and post-renal, the causes are different, but the pathophysiology is really the same. You have less glomerular filtration because the pressure gradient from the afferent arteriole to the Bowman space is reduced. And so that's why, when you go back and look, the labs are pretty much the same. Because what we're going to want to do is we're going to want to increase our reabsorption. So we can, if we increase our reabsorption, what we do then is we will either increase our amount of fluid that we have in the afferent arteriole, which would raise our pressure here, or we will reduce, if we reabsorb from the nephron, if we reabsorb fluid, we're going to reduce our back pressure on Bowman space. So what we're doing is we're just, with pre-renal and post-renal, you're going to have an enhancement of reabsorption of water and sodium, but it's going to be for different reasons. For pre-renal failure, it's going to be to increase our fluid in the bloodstream, and for post-renal failure, it's going to be to reduce the back pressure on Bowman space. Now, we'll come back to this slide several times throughout the nephrology section. Okay, so let's kind of go over that in a little bit more detail. So pre-renal azotemia. What is the cause of pre-renal? In general, it's just decreased perfusion. You have decreased perfusion to the kidney. The kidney senses less perfusion, so what's the kidney going to think? It's going to think, well, gee, I need to increase my reabsorption of sodium and water because the body needs to preserve water if I'm not getting enough perfusion. And so what do we do to preserve water? Well, we're going to reduce the amount of sodium we excrete in the urine. If you have more sodium in the urine, water is going to follow it, and then we'll be losing water. So that's not good. So we reduce the amount of sodium going into the urine. How do we do this? We just increase the amount of reabsorption of sodium. So by avoiding urinating sodium, we avoid excreting water. And so that's why the fractional excretion of sodium is low, because we're not getting rid of sodium. Our urine sodium is low because we want to preserve volume. Because remember, the causes for pre-renal azotemia are anything that causes low perfusion: hypovolemia, septic shock, cardiogenic shock, renal artery stenosis. Now, because we're not getting rid of water, because we're reabsorbing water and not getting rid of water, the urine is going to be concentrated. So the urine osmolality is going to be high. So because more volume is preserved, there will be less water in the urine, and the urine osmolality will be high. Remember, any time we have an enhancement of reabsorption, we're reabsorbing sodium, we're reabsorbing water, we're going to have a high reabsorption of blood urea nitrogen. And so our BUN creatinine ratio will be around 20-1 or higher. And like I just said, the causes for pre-renal azotemia are anything that causes decreased perfusion to the kidneys. So renal artery stenosis, hypovolemia, septic shock, cardiogenic shock, decreased aldosterone, hypoalbuminemia, and hepatorenal syndrome. Now, on the other hand, post-renal azotemia, you're going to also have problems, but in this case, it's going to be an obstruction. So the obstruction causes increased pressure in the Bowman space, right here, and because of that, it's going to impede glomerular filtration. Why? Because we have a higher pressure in the in the Bowman space, and that's going to reduce our gradient. So because of that, we're going to want to reabsorb water. Why do we want to reabsorb water in this case? Well, in pre-renal, we wanted to reabsorb water because the kidney senses a decreased perfusion. In post-renal, we want to reabsorb water so we can reduce the urinary volume. That helps us in post-renal because the problem is excess pressure. That back pressure is causing the problem. So by reducing the urinary volume, we're going to reduce the pressure transmitted back to the Bowman space, which is the initial cause of the post-renal azotemia. So it's going to be the exact same thing. By reducing absorption of sodium and water, we're going to have a low urinary sodium, and because we're going to have less water in the urine, we're going to have a high urine osmolality. Because we're increasing our reabsorption in general, we're going to increase our reabsorption of BUN creatinine, but the BUN and creatinine ratio is going to be at the upper limit of normal, possibly even within normal limits. It's not going to be quite the same as pre-renal, and that's one way you can distinguish it. But in general, you should be able to distinguish pre-renal from post-renal in general, just on how the patient presents. And that'll become more obvious when we talk about individual causes of pre-renal and post-renal. So the causes are stone, obstruction in the urethra, bilateral urethral stone, prostatic hypertrophy. And the treatment is going to be the underlying cause. Now we contrast pre-renal and post-renal to acute tubular necrosis and acute interstitial necrosis. And that's pretty much where the kidneys, namely the tubules, don't function. So if the tubules and the interstitium don't function, what you're going to have is you're going to have no reabsorption whatsoever. So if we have no reabsorption of sodium, the urine sodium is going to be high because that sodium is just going straight out through the urine. And if the urine sodium is high, the fractional excretion of sodium will be high too, greater than 1%. If we don't have reabsorption of water, water is going to go out the urine. So we're going to have a dilute urine, so the urine osmolality will be low. If we have no reabsorption, then we're not reabsorbing BUN at all, and so the BUN creatinine ratio is going to be low, less than 10-1. And the causes for this are various. So looking back, we see that because the underlying cause of post-renal and pre-renal are different, but the pathophysiology is the same, pre-renal and post-renal are going to have very similar lab values. The difference comes with the internal causes of renal failure as opposed to the external, the pre-renal and the post-renal. So we can differentiate acute tubular necrosis and acute interstitial necrosis from glomerular problems, because what we're going to see is red cell casts and hematuria in the glomerular causes, and we'll see brown casts, epithelial casts, or eosinophils in the ATN or AIN. And we're going to see relatively normal values for urine sodium and fractional excretion of sodium and urine osmolality, similar to post-renal and pre-renal, because in the glomerular causes, the tubules are functioning fine. The tubules are responsible for our urine sodium and for our fractional excretion of sodium and for our urine osmolality, because that's where all the reabsorption happens. When you see high urine sodium, high fractional excretion of sodium, low urine osmolality, and low BUN creatinine, that is pointing straight to tubular necrosis or interstitial nephritis. And so that's what we will see when we have those. So let's just kind of look at the various causes, and we'll go over these in a different section. For pre-renal, we have renal artery stenosis, hypovolemia, septic shock, cardiogenic shock, hypoaldosteronemia, which is Addison's disease, hypoalbuminemia, and hepatorenal syndrome. For intrarenal, it's anything that causes damage to the kidney tissues. So we have the tubule interstitial diseases, which cause acute tubular necrosis and interstitial nephritis, and then the glomerulonephritides, which cause damage to the glomerulus. And then our post-renal causes, which is pretty much anything that causes obstruction to urinary outflow, and that's urethral stones, benign prostatic hypertrophy, bilateral urethral stones, and bilateral metastases to ureters. And that is it.